Take a look at these two patients. They both have undergone the same surgery in the same hospital, same OT, and even the same antibiotics. But why is one patient's wound like this? It's very healthy, and the other patient has developed wound dehiscence. So that's exactly where our today's video comes in play. It's about wounds and surgical site infection. Hello guys, I'm Dr. Adarsh, and today I'll help you understand the most basic thing a surgeon should understand, because as a first year resident, your main job is to manage the post-op patients, their dressings, their wound care, right? And also it has to be a first priority to make sure a patient doesn't end up with surgical site infection. So what exactly do you have to focus on? How does the SSI develop? What are the factors you have to focus before the surgery to prevent the SSI? So I'll help you understand all these things in today's video. So first, let me ask you a question. What exactly is a wound? There's a laparotomy incision and there's a gunshot injury. Can both be called wounds? And the answer is yes. A wound is nothing but disruption of normal tissue integrity, and it can be disintegration of just the epidermis or even the whole thickness of the skin. And no matter what kind or what mechanism has made the wound, the healing principle will remain the same. And the wounds can be classified by the mechanisms like incised wounds, abrasions, laceration, puncture wounds, or a crush injury, right? Depending on the mechanism, you can classify the wounds in different kinds. But what classification do surgeons need? That's called a CDC classification of surgical wounds, and they are divided into 4 types: the clean wounds, clean contaminated, contaminated, and dirty. So what are the clean surgical wounds? The surgeries where you don't enter the GI or GU tract are called clean wounds. Like for example, hernia surgeries, breast, thyroid, cardiac surgery, varicose veins, all these come under clean wounds, right? Here you are not entering in the GI tract or the genitourinary tract. So these carry the least amount of surgical site infection risk, that is 1 to 2%, right? Next, coming to clean contaminated wounds. So these are the surgeries in which you enter the genitourinary tract or the GI tract, but in a prepared manner or in an elective manner. Like for example, you're doing an elective cholecystectomy or an interval appendectomy, or you're doing a PCNL for a renal calculus. So all these come under clean contaminated wounds, where you're entering the GI or GU tract in a controlled manner, or you have already prepared the bowel, right? And these carry a little bit higher risk of infection than clean wounds, like 2 to 4%. So next, coming to contaminated wounds, and these are the same surgeries which you did in the clean contaminated wound, but these are done in emergency settings. Like for example, acute appendicitis or appendicular abscess or acute cholecystitis, where you have not prepared the GI or GU tract initially, or you have well prepared elective case but there is a breach in the sterile technique. Like for example, during an elective lap chole, there is bile leak due to gallbladder rupture, right? That comes under contaminated wound. So any break in the sterile technique will come into contaminated wounds. These kind of wounds will carry 10 to 20% of infection risk. And the last ones are the dirty wounds, where there is gross contamination. Like for example, in perforation peritonitis, in a case of abscess, or if there's a case of gangrene. So all these cases will come under contaminated, where you can see the gross contamination and there is a sure evidence of bacterial contamination even before you do a surgery. And these cases have up to 40% risk of surgical site infection. So that's why giving prophylactic antibiotics is a vital step whenever you take a patient for surgery. So you have to give antibiotics at least 1 hour before the skin incision. So that will reduce the surgical site infection significantly. And this is a table for you to understand, to compare the infection risk without antibiotics and with antibiotics. So now that you know the different kinds of surgical wound, let's understand how wounds heal exactly. So you know in what step is the actual problem when it comes to a surgical site infection. So there are 4 phases in wound healing, and I'll be very short. The first phase is hemostasis, which occurs within seconds, and there's a fibrin clot formation, right? After that, the second phase begins, which is called the phase of inflammation, where the neutrophils and macrophages come to the site and they clear all the debris and bacteria. The third phase, which starts from day 4 to 21, is the proliferative phase, where the fibroblasts dominate and the collagen production increases. Along with that, there is neovascularization and angiogenesis. So this is called the granulation tissue, right? And the healthy granulation tissue looks like this, bright red and bleeds on touch. And the phase 4 is remodeling phase, which will take up to weeks. And one more important thing, a healed wound will never regain its original 100% strength. The maximum strength it can gain is up to 80%, right? So understand this phases of wound healing in short, because you will be needing it to assess a patient with SSI. And what are the reasons surgical site infections occur? And most commonly, it's due to a local cause, and out of which hematoma is the most common cause. Why? Because bacteria just loves hematoma. So whenever there is a hematoma, there is bacterial proliferation, and which later will lead to SSI. Second condition can be there's a dead space, right, where the collection forms, either the seropurulent correction or whatever solution you're using for dressing, like your betadine, like your gauze piece, right? So any collection in the dead space can become an nidus for surgical site infection. The next reason could be a foreign body, a suture, mesh, or any debris can act as a source of surgical site infection. And another main local reason is a poor blood supply. And poor blood supply can be due to a poor surgical technique or the systemic factors. And poor surgical technique, like for example, you gave the skin suturing to your intern and your intern just strangulated the tissue, or there was a cautery burn on the skin. So these were the local causes, and the systemic causes like immunosuppression, diabetes, smoking, obesity, malnutrition, all these other causes. So what do you think is more important, a cosmetically good suturing or the blood supply? Obviously, it's the blood supply which takes priority. So what exactly is the surgical site infection? Any infection occurring within 30 days of surgery or within 90 days of an implant placement is called a surgical site infection, right? And surgical site infection can be superficial, deep, or organ space SSI, depending on where is the infection. If it's in skin and subcutaneous tissue, it's superficial. If it's in the fascia or in the muscle, it's called a deep. Or if it's in the organ space, like an intra-abdominal abscess or an anastomotic leak or pus collection in an organ, that's called organ space SSI, right? So I want you to differentiate between these three, because the management will differ in each of these cases. So how to prevent this SSI? There are only two principles. You have to reduce the bacterial load and you have to improve the host defense, right? These are the only two things you have to focus on. So how can you reduce the bacterial load preoperatively? Give a prophylactic antibiotics 60 minutes before the incision. Parts preparation, that is clipping the area and not shaving, right? And intraoperatively, gentle handling of the tissues to make sure there's no spillage or no break in sterile techniques. Adequate hemostasis so that there's no hematoma left when closing the surgical site. Make sure the patient is not in hypoxia, that is maintain adequate oxygenation, and avoid hypothermia, because hypothermia can induce surgical site infection. And post-operatively, wound care, very important, and the drain management. So we'll learn about the dressings, drains, and drain management in a separate lecture. And what about improving the host conditions? That is making sure the patient has adequate glycemic control, encourage smoking cessation, and also adequate nutrition. So if you focus on this, you will be minimizing the surgical site infection to its minimal. But what if even after trying your best, still the patient develops surgical site infection? What to do then? Then you will have to optimally manage the surgical site infection. For instance, take a look at this patient. It's a post-op day 3 and the patient has developed redness and seropurulent discharge from the surgical site. What will you do? And don't say just giving higher antibiotics will help. No. First thing is address the local site. Clean it, evacuate the pus, and do proper dressing. So remember a golden rule, wherever there is pus, you have to evacuate it. No exceptions for this. It doesn't matter if it's an abscess, if there is a pus in an organ, pus in the abdomen, pus in a surgical site. One simple rule, if there is pus, you drain it. That's it. Stepping up to higher antibiotics or optimizing the patient is not going to help. So your next immediate step whenever you see a pus is to drain it. So the management would be open a few sutures, take a swab, send pus culture, and then do thorough irrigation of the wound. Right? You can milk the wound and you can irrigate the site with saline. So you have to be doing a regular dressing, and it would be better if you can do the dressing twice for the first few days. And this is one of the most feared wound complication, and it's called a burst abdomen. and this usually develop between post-op day 5 to 8. And there are various factors, and you can think of all the factors which we had discussed for the high risk for SSI. That is poor nutrition, poor surgical technique, or uncontrolled diabetes. The patient has not stopped smoking cessation. Every reason you can think of can cause this post-op complication. So what are the signs which you can suspect for burst abdomen is the patient will have a serosanguinous discharge. It's typically called a salmon fluid discharge. So it will appear pinkish color, salmon in color. So that's a sign that the sheath has given way and the peritoneal fluid is coming out, right? And when you examine this wound, you can see there is gap in between the sheath, and later the intra-abdominal contents can protrude out. Intestine, omentum, everything can come out. So if the patient has burst abdomen, you have to do something called urobag laparostomy to prevent the evisceration of the intra-abdominal contents. What do? You cut the urobag and you suture it on the abdomen in a flap kind of fashion. Or you can do en-masse closure of the abdomen using a thick suture like Prolene 1 or Nylon 1. Or if there's gross contamination, then you can keep the abdomen open and you can place a mesh to prevent evisceration of the bowel. And you can do daily dressing, and it would be better if you do dressing 2 times daily. Wash the contamination with saline thoroughly and place the urobags back, or you can place a mesh as well. And do this until granulation tissue covers the abdominal wall defect. And there's another technique you can use that's called a negative pressure wound therapy. So we'll discuss even that in the next lecture, that is in dressings and wound care. So if the patient develops purulent discharge from the midline wound on post-op day 2 or 3, then you can just open all the sutures, give thorough wash, and start negative pressure wound therapy for that wound, and it's gonna heal excellently, and later you can do the secondary suturing. I hope this video has helped you in understanding surgical site infection and its care better, and I really hope you can apply this in your day-to-day practice so that you can prevent SSIs as much as possible. So keep learning and keep working hard to be the best surgeon.